Welcome back to IBD Essentials. My name is Florian Rieder from the Cleveland Clinic. I'm the co-host of this series. We are happy you're back with us. Remember, you can like us. You can also subscribe to our channel. And anything you see on our channel, we are welcoming your comments that we can then respond to or can make this series better. But you can also discuss what you feel about the videos and the topics and voice your opinion. With no further ado, it's my pleasure today to welcome Professor Saurabh Mehandru from the Mount Sinai in New York, who is a distinguished immunologist in the field of inflammatory bowel diseases. And the topic of today will be B cells in inflammatory bowel diseases. But before we dive in, Professor Mehandru, if you could just introduce yourself and let us know, how did you end up in New York and how did you become a physician scientist?
Very nice to meet you. Thank you all for being here. So I trained initially as a physician in India. Once I moved to the US, it gave me the opportunity to actually access very high-powered, good labs. I always had an interest in research. That is why I moved to the US. And it was during my training that I actually got into initially one, and then eventually I liked it so much that I stayed in the lab for about 10 years, working on understanding the immune system, specifically the immune system of the intestines. That's called the mucosal immune system, because it's very different from the immune system that is there within the rest of our body. And that's how actually I got started in the field of IBD, by my interest in the mucosal immune system.
So we were drawn by the opportunities and by the mucosal immune system, and then ended up in a very good place in New York. And you also still see patients. You have an active inflammatory bowel disease practice, or a true physician scientist in the space of IBD.
Yes, I actually see patients. So I'm fortunate that I work at Mount Sinai, which is where Crohn's disease was initially described. Burrell Crohn described Crohn's disease along with his colleagues Oppenheimer and Ginsberg in 1932. And at Mount Sinai, we've always had a very strong presence of inflammatory bowel disease. In fact, I now direct the IBD Research Center at Mount Sinai, and we have among the largest cohorts of IBD patients in the country.
Oh, very impressive. So the topic today is a topic close to your heart, which are the B cells.
Yes.
And you're in the right time, in the right spot for studying B cells. We'll come to that at the end. But for our audience of gastroenterologists, if you could first describe what are B cells, what different kinds of B cells are there, and then after that, what is their role in health? So why do we need B cells?
Exactly. So B cells are a kind of immune cell that produces antibodies, and their sister cells are called T cells that produce chemicals called cytokines. So both of these cell types are actually what we call as adaptive immune cells, meaning they have to be trained by the body in order to fight specific targets. So they're very specific cells. For example, when you get a vaccine, that vaccine will induce your B cells to produce antibodies, and that's how you actually, when the infection comes or whatever you've been vaccinated against, that is how you recognize and fight it. So B cells are traditionally thought of as cells that produce antibodies, and those antibodies can travel anywhere in the body, so they don't have to be local. And that's why it's a part of the immune system that is called the humoral immune system, meaning that it can just go through the blood anywhere in the body. But B cells also have a lot of other functions which have somewhat been dwarfed by their antibody producing function. That include some critical immune functions like making chemicals like cytokines, also helping with the immune response. And they do, as you indicated earlier, they have an important role in protecting the health of the body, just as T cells do. But B cells in specific, they assume more importance at the lining surfaces, at the mucosal surfaces, because they produce antibodies that are called IgA antibodies. And what these antibodies do is that they actually interact and they control the microbiota that is living within us. So they prevent the microbiota from invading, and they also do it in a way that does not induce inflammation. So they're considered to be good cells that are important for regulating the local environment of the intestines. But if I were to extend this logic, I would think that any immune cell that is there, it's there in the body because it serves a function. It's just that the B cell function is to produce antibodies. Same way T cells have a function, same way other immune cells have a function.
You mentioned mucosal B cells making predominantly IgA. There are other IgGs. So what is the difference between the circulating B cells, the B cells in the lymph nodes, the B cells in the mucosal immune system, and how plastic are they?
Right. So that's a very good question. What happens, or the way we think about cells in circulation, is that those cells, first of all, those are the cells that have been the most studied. Those are the cells that are actually easy to access, and we know a lot about them. And there's different kinds of immune cells in circulation. But once they go into the mucosa, into the lining of the intestines, they have to become specialized. They have to become cells which will target or perform specific functions. Now, for the B cells, not just in the mucosa, these cells they start off like any other cell as what is called a naive B cell. So that B cell is a cell that, for example, will come out of the bone marrow. It's not yet seen what it needs to fight. Once it actually recognizes its target, it will then mature and become what's called a plasma cell. A plasma cell is a mature form of B cell, but it has specialized a lot to produce antibodies. So B cell can have different kinds or different phenotypes, as we call them, but a plasma cell is sort of the late stage of a B cell that is now a very, very specialized cell producing antibodies. In fact, it becomes like an antibody producing factory, and that's how we think of these plasma cells.
And which other cells do B cells interact with? So they make the antibodies can have functions, they can have induce autoimmune phenomena and so forth, but does this B cell itself also interact with other cells?
Yes, and I know where you're leading me. That's a very good question. So B cells, one of the things that actually B cells were recognized to do is to train T cells. So B cells will interact with T cells and they'll educate the T cells, and that's one of the ways by which T cells become super specific and become reactive to the things that they need to fight. So they have a role in educating T cells. They probably interact with other immune cells as well, including cells, for example, that I know you're interested in, which are called stromal cells and other cells. And again, those are things that are areas for further research. But for the purposes of this conversation, let's just say that B cells have a very important role in educating and, as we call it, priming or training T cells to perform their function.
Very good. Thank you for all these explanations. And before we dive into IBD, B cells are underappreciated in IBD, which we learn now, and which, thanks due to you, I think we raise awareness about B cells in IBD. But they are very well recognized in other immune-mediated diseases. So, which diseases do B cells have a major role in immune-mediated diseases, and then how were they therapeutically targeted?
Right. So, like every cell, so cells are there in the body to perform specific functions, but then there are diseases that are associated with those cell types. So there are some traditional diseases that are B cell associated, and those B cell associated diseases, for example, will include conditions like lupus or conditions like rheumatoid arthritis or conditions which are associated with an autoantibody production, meaning antibodies have been produced by B cells and they will target the body itself. So those are considered to be traditional antibody-driven diseases, but now we are learning that a number of other diseases, so for example, diseases like myasthenia gravis, diseases like Goodpasture syndrome, a number of other diseases also have a B cell component to them, where B cells either directly cause the disease or may facilitate the disease in different forms by interaction with other immune cells.
Hmm. And then, how have they been targeted?
Yeah. So we learned actually a while ago that there is an antibody, that there is a receptor on B cells which is called CD20. So if you produce an antibody that targets CD20, that specific antibody can actually kill the cells that express CD20. So that is one way you can have antibodies that attach to specific receptors on B cells, and they can lyse the B cells. There are a lot of other mechanisms of targeting B cells. I think the one that has become the most, let's say, talked about recently is this approach of inducing a chimeric population of T cells that are called CAR T cells, that you can design them, you can engineer them to attack specific receptors on almost any cell type, and that also includes receptors on B cells. So, for example, there are CD19 CAR T cells that will attack the B cells that express CD19, or there are other kinds of CAR T cells. One of them is called BCMA CAR T cells that will attack a different population of B cells that expresses BCMA. So, there are these approaches as well.
Mhm. Before we move to IBD, what have been successes and failures of targeting B cells in immune-mediated diseases?
Right. So when it was recognized that B cells actually cause certain, diseases like lupus, so the approach to treating these diseases, of course, because they're inflammatory diseases, so you can give anti-inflammatory drugs, but they're non-specific. Then the approach became to give specific antibodies. So, for example, rituximab or Rituxan, which is an anti-CD20 antibody, and that can be used to target CD20 expressing B cells. So, this approach has met with success. And more recently, there have been dramatic success stories of, for example, CAR T therapy in the context of diseases like refractory lupus. So these are patients who've actually become refractory to almost any medication, and they're debilitated, they cannot function. And by using the CAR T approach, in instances, even cures have become possible. And by cure, what we mean is prolonged absence of disease in the absence of therapy.
Mhm.
So, encouraged by this dramatic success of CAR T driven treatment of these B cell diseases, I think the B cell field is energized. The B cell field thinks that there is not just the role in protecting the body, which is more of a research associated role, but there's also a role in now coming specifically at B cells in situations where B cells are becoming disease associated or disease causative.
So we are all excited about this, truly, and about the therapeutic prospect. So you already gave a nice segue into IBD. So B cells become dysfunctional. They lead to damage and inflammatory bowel disease. Uh, how does that happen? And then Rituxan has been tested in IBD, but for some reason, no success. So why do you think that is?
Right. So first of all, it's been, I think, long recognized. There are investigators like Per Brandzag, like McPherson, a number of investigators in the 70s, 80s, 90s have recognized that IBD, in fact, is in part associated with B cell dysfunction. Uh, in fact, the traditional description of IBD pathology is that there is a lymphoplasmacytic infiltrate, meaning there are lymphocytes and plasma cells in the lining that comprises of the IBD lesions in the intestines. There's also a finding which is called basal plasmacytosis, which means that a layer of B cells or plasma cells actually comes between the crypts of the epithelium and the muscularis layer. So these are old traditional pathological descriptions that have been accepted as mainstream sort of findings associated with IBD. But we don't particularly pay attention to B cells in IBD therapeutics, and I think the reasons are Number one, that B cells traditionally have been thought of as protective cells, as we discussed earlier in the conversation, that they produce IgA, which is important in maintaining the defense against the microbiota. So that's one reason. Another reason is that a trial of rituximab was conducted. I think it was reported in 2013. It was a small trial of about 24 people. So it was underpowered. And in that small trial, if you go into the depths of the results, you can see that there was perhaps a signal, but that signal was not significant because of the size of the trial. That was also the time when a lot of new medicines were coming out. So compared to some of the newer treatments like TNF inhibitors and then subsequent drugs which were highly effective, it was felt that maybe targeting B cells is not going to be as effective.
Mm-hmm.
So when we got into the field, it is actually sometime, I think around 2017, we started with a very simple, premise, which was that knowing what we know about the immune system, we know that immune system usually does not work in isolation. So it will not be that T cells will work in isolation and cause disease. Usually different players within the immune system, they collaborate with each other, they partner with each other. So initially we asked a very simple question when it was not fashionable. What is going on with the B cells? How are B cells essentially shaping up in people with IBD in circulation and in the intestines themselves? And initially, what we did was replicated the work of people that preceded us. So, for example, it was described, by a number of investigators before us that IgA, which is the main antibody in the intestines, the proportion of IgA becomes less in inflammatory bowel disease, and the proportion of IgG increases in inflammatory bowel disease. This was already known. So when we started doing this work, we found the same thing, that there was a lot more IgG in the intestines in people with inflammatory bowel disease. Now this becomes important because unlike IgA, which does not result in interaction with other inflammatory cells and causing inflammation, IgG can interact with, for example, neutrophils or macrophages, and it can cause inflammation by triggering the release of cytokines, which then draw in other inflammatory cells.
Mm-hmm.
So I think this is not a new finding, but this is still a significant finding because IgG has inflammatory potential. So one thing we saw was that IgG is more and therefore could be associated with inflammation. But of course, in 2019, 2020, we have much better tools to study the body. We have much more precise and sophisticated tools. So using those, we could find certain, let's call them certain qualitative changes in B cells, which were telling us that these B cells are more peripheral B cell like. They've not been adapted to the environment of the intestines. So their characteristics make them more pro-inflammatory. But I think the real, in tangible terms, I think it became super exciting when we discovered that one of the plasma cells was actually producing an antibody that targeted the lining of the intestines. And that antibody has since become of great interest in at least in ulcerative colitis, but also in a subtype of Crohn's disease with colonic inflammation. That antibody is called anti-alpha V beta 6. So we were able to identify a plasma cell which is producing anti-alpha V beta 6 antibodies. Now, again, for context, a group in Japan had previous to us described that these anti-alpha V beta 6 antibodies, they're enriched in people with ulcerative colitis. What we found, first we confirmed what they had said, but we found that these antibodies were actually being produced by intestinal plasma cells. So plasma cells had become dysfunctional and they were targeting a protein that was expressed by the epithelium. And then, of course, there have been a number of other studies, recent, including studies from Home Ulick, that has shown that anti-IL-10 antibodies are associated with severer forms of Crohn's disease as well as ulcerative colitis. There are GM-CSF antibodies. So together, I think a consensus is emerging that there is also a B cell component to the inflammatory milieu of the intestines.
So there's a rationale to target them.
Yeah.
And seminal work you've done with alpha B beta 6 and very impressive, I think will become relevant. Before we wrap up, two questions. So there are patients that have been reported that received rituximab that actually developed colitis.
Yes.
And then I would like to ask your opinion on the most recent reports in New England Journal of Medicine where severe refractory ulcerative colitis, you described it for lupus and CAR T cells, severe refractory ulcerative colitis received CAR T cell therapy and improved. And why is there a disconnect between using an antibody and using a CAR T cell?
Right. So first of all, regarding rituximab. So on the one hand, we discussed the rituximab is not very effective, at least in that trial. I think one reason I forgot to mention is that the cells in the intestines, particularly plasma cells, they downregulate the receptor that rituximab targets. So they downregulate CD20, and it's probably not as effective in counteracting the CD20 now negative plasma cells in the intestines. Now, it's been also known that rituximab and B cell targeting can induce inflammation, perhaps because you're causing a severe loss of certain cells which would have protected the body. But it's a very non-specific depletion of these cells. So, for example, if you're killing off all the cells and then that is causing inflammation, you don't know if you've also killed off some of the cells which were essentially either producing regulatory cytokines or producing critical antibodies. You don't know if the microbiota in these individuals were different. You don't know if they had genetic predisposition to inflammatory bowel disease. So there are anecdotes of people getting inflammation after rituximab or ocrelizumab treatment. And I think that's another reason which you rightly point towards that has kept the B cell field somewhat, away from IBD therapeutics. But I often say that it would be the same as saying if you kill all T cells, because T cells are being targeted in IBD, but you have to be specific. We know a lot more about T cells and the cytokines that the T cells are producing so that we can target them specifically. We don't know as much about the B cells in terms of what distinguishes the homeostatic or physiological B cells from the ones that are pathogenic. So right now the approaches have been to kill all B cells, which are, they may in maybe 2%, 3% of cases also cause side effects such as inflammation itself. I think the second question that you asked has become really interesting. Is that a group from Erlangen, Germany, led by Professor Neurath, Professor Raja Atreya, and also by Fabian Müller, they achieved a very dramatic result. So they were faced with a patient who was refractory to almost all treatments. She had failed all available treatments and was very, she was a young woman, and we understand her rationale for not wanting to undergo a colectomy. She was very vehemently opposed to a colectomy. So then in discussion with that patient, what the group in Germany decided was to try first an antibody. It's called a TB engager. They tried that TB engager to see if that would work, and it worked in her for a short period of time. So then they felt that maybe there is a path forward, but maybe with the antibody, they're not achieving a deep enough B cell depletion. So it's somewhat counterintuitive to what we just talked about. But in this pathogenic situation, where this patient had failed 8 or 9 different medicines, so they then decided to actually treat this patient with a CAR T antibody, or CAR T approach rather. What they found was that this patient showed a rather dramatic response. So she went from being unable to function, being bedbound, to now being functional in the absence of treatment. And it's almost a year now. And from what I heard from Professor Treya, she continues to be fine. She continues to actually not need treatment. And she's actually showing what is called mucosal healing just by targeting the CAR T cells with a CD19 CAR T. So this has revolutionized the field. It has provided real evidence that there are subsets of IBD patients where B cells may be important in driving disease, and you may want to target those B cells. And because of the importance of this case, it was published in the New England Journal. I think that these are still early days. I think we need to understand and know a lot more. And I know that that the group in Germany, we ourselves, we are very interested in this. We are actually actively pursuing this area to understand, which are the groups of patients that should be targeted, to understand how to follow the safety of these patients, and then also to understand what cell types and how to monitor these patients in terms of biomarkers that will help us follow them. But this is a very exciting and active area of investigation. It adds another dimension to IBD treatment. Right now, for people who are failing, different treatments, but I think in the near future, I can imagine that this will come even at earlier stages of IBD treatment as we understand the safety and as we understand the specificity of B cell response in IBD better.
Before we wrap up, one quick question. You were leading into it already, what I wanted to ask earlier. Depleting B cells and safety, what are safety one needs to look for if this were to become a therapy in the future?
I think we need to make sure that we follow not just the inflammatory, situation of the intestine. So there are biomarkers commercially available, clinically used, like calprotectin, for example. There are non-specific inflammatory markers like ESR, CRP, which we follow. But I think also what is yet investigational are changes in the microbiome, changes in the immune system that we need to follow. Those, of course, will be more investigational. I think we need to make sure that if we are treating the B cell response, that we are not causing inflammation, because B cells, as we've discussed a couple of times, do have protective roles for the intestines.
And risk for infection, depleting B cells?
Actually, the risk for infection is the mucosal immune system has a lot of redundancy. So risk for certain infections, for example, Clostridium difficile infection, or risk for other, we've seen instances where there have been like colonization with viruses, or colonization, for example, with Salmonella. So there is a risk of infection with deep and prolonged B cell depletion, but usually those infections are either treatable with antibiotics, or in the case of viruses, I think there are some approaches that can be used to mitigate those risks.
So exciting times. Thank you so much for guiding us through B cells, their subtypes, B cells in health, immune-mediated diseases, and arriving at the future in inflammatory bowel disease. B cells are coming back strong. And we're looking forward to more data from you, from the Erlangen group in the field. So thanks so much for coming, and I'm sure we will have you back in the future.
It's my pleasure. Thank you very much.
Thank you for joining, and I wanted to remind you again, you can like us, you can follow our channel, and also you can comment on Professor Mehandru's video as well as on any other video we generate. Thanks so much, and have a good rest of the day.